Just we remind everyone, this is for everyone, this is lecture part from serial lectures organized by SWIPE Africa Education Program and Training Committee. Lecture will be held every Wednesday, exceptional today. And this week also we have the Wednesday lecture, will be by 3 p.m. at GMT time. Please make sure you register in each lecture, and 80% of attendance required in order to eligible for certificate. During this lecture, all participants please mute it and ensure smoothly presentation. However, we encourage you to active participate by typing your question in the chat box. By end of the session, we'll able to answer and discussing the question. It's my great pleasure to introduce our distinguished speaker for today's session, Prof. Reham Hammad. She is leader of clinical pathologist and head of flow cytometry at Al-Azhar University in Egypt. She brings her extensive experience in clinical pathology and flow cytometry and hematological diagnostic, and also contributed significantly in advanced pediatric oncology and hematology in Africa and beyond that. Also, she is academic and clinical leader. Prof. Hammad is deeply involved in education and training and mentoring young professionals in laboratory of medicine and diagnostic science. She will present it today, Immunophenotype in acute leukemia. Thank you, Prof, for your time today. Apologies again regarding the technical issue. You can starting your lecture.
Thank you so much. Actually, I don't mind some technical problems. Inshallah, they're not going to be repeated. I was talking to myself the last 10 minutes to repeat what I was saying. As you can see, I wanted to summarize some of the data we are taking. The last lecture of the fundamentals of flow cytometry. And now you can see that one of the fundamentals that we use, antibodies, those are coated with fluorochromes, and those fluorochromes are usually have a specific characteristic as when they are going to intersect with the laser, they are going to emit light, and this light is going to be transferred to electricity and digitalized to appear as a dot in my graph, representing the size and the granularity of the cell. As I do want to remind you that the graph we have been taking to study the normal in order to understand the abnormal when we see it in the state of diagnosis of leukemias, that this graph, which represents the forward scatter and the light scatter, and now you can see the dots we are dealing with, those are the digitalized events which appear by the flow cytometry in relation to the size and the granularity of the cells. Here in the left outmost part, you can see there is the site of the debris and the residual RBCs and the platelet. While you are moving into the right side, you are going to see the population of the lymphocytes and the basophils. Going to the outermost right side and increasing the intensity due to increase of the size and the granularity of the cell, you will find the monocytes, then comes the neutrophils, and in the uppermost part is going to lie the eosinophils, which are which is taking this place due to the high intensity of their crystalline granules they have inside. So they have severe intensity on the side scatter and the forward scatter according to the granularity and the size. Now you can see this graph, which represents the difference that I do want you to know by heart, whether you are going to use CD45 or you are not going to use the CD45. All the recommendations of the Euroflow panels, those are used nowadays. They use the CD45 population, and now you can understand why. Because as you can see in here, if you are going to reach the diagnosis to locate a blast, which is going to take the purple, the light purple color in the forward scatter, side scatter graph, you can see that this blast is actually integrating with the lymphocytes and the monocyte. There is no sharp demarcation between the population. The black part represents the debris And the red population represent the neutrophils and the eosinophils, both integrated together. While if you are going to use CD45 and you are going to use it instead of the forward scatter in relation to the side scatter, you will find a wonderful demarcation of the population. Now you can see that the black debris lies in the outer, in the leftmost part, and then with a space, you will find the purple part, which is lying in the window phase or the window area. This is what we call the blast area. And lies in the right outmost part is the lymphocyte due to its highest intensity of expression of the CD45. Moving up is the monocyte, and then the red population now is more demarcated and more sharply localized. And beside it, you will see the separation between the neutrophil in that color and baby blue color of the eosinophils. So speaking generally, which one do you prefer to use? A forward scatter, side scatter in order to locate your blast, or a CD45 versus side scatter in order to locate blast? Which one do you prefer? I need you just to answer in the chat. Which one do you prefer? The forward scatter, side scatter, or using the CD45 for demarcation of population and the side scatter? Which one do you prefer? Anyone? Yeah, definitely. I do agree with you. CD45 is going to be the best choice if you are going to separate the populations you are going to use. Put in your consideration that now we are using panels. Those are prepared by the Euroflow panels, and most of them, and all of them are actually using the CD45 as a backbone in all of the tubes that you are going to introduce to the flow cytometry. Remember that if you are going to conjugate the antibodies and you are not going to use the Euroflow panels due to economical reasons or any reason, please remember that if you are going to look for an antigen with a low density, please remember to use a fluorochrome with a high intensity, so that when you conjugate the low intensity antigen and the high intensity stain, you will find out that you will get an answer for your questions, and the population is going to appear in your diagram. Now, as we have revised some of the very few data we have taken in the last lecture in the fundamentals of the flow cytometry, we are going to enter, inshallah, directly to the immunophenotype of acute leukemia. Let me remind you with this picture, as I want you to revise it by heart, the difference between the forward scatter, side scatter, and the site of the blast that you demarcate in the purple population, which is the site of blast. This is the most common site. Is it the only site? No, you can never say that. It is the most common, which lies in the DEM45 location. This is what we call the window or the blast area using CD45 and the side scatter. Please remember this site quite well. Please also remember that this is not the only site where you can find your blasts. And many of you who are using the flow cytometry in diagnosis, or those who are going to use it, will find that it is most commonly, they do not, in so many times, they do not lie in this area. So let's try to set our mind in a right way and to find out how we are going to diagnose leukemia. What are the characteristics of the questions that we have to answer in order to diagnose leukemia? Number one, I have to know the normal by heart. And then I will ask myself, is there any abnormal population representing precursor cell type or blast in my diagram? Then the second question is going to be, what antigens do those blasts express if they are found? Then, what is the lineage and how do I make the lineage assignment? And question number 4, is there an apparent expression? And now we will say that the apparent expression is an abnormal expression from the lineage that I have assigned the population to. So those 4 questions are going to accompany us while we are moving to the journey of diagnosis of leukemia. Once again, the red part, which represent the blast area using CD45 side scatter, and now you know this definitely by heart that this part is actually correlating to the blast area. This is what we call blast window. As we have said, this is not the only part where I can find the blast. Actually, sometimes, according to the lineage of the blast, the site can be different. Sometimes the myeloblasts have even a moderate expression of CD45, so they do not lie exactly in the dim area, but they move toward the right side, toward the lymphocyte area to have a moderate expression of CD45. Sometimes the monoblasts have a brighter and brighter expression of the CD45, and they lie in a higher side scatter range than the myelocyte, and they lie above the normal residual lymphocyte. The promyelocytes actually lie in the neutrophilic area if they are of the hypergranular classical type. While if we are talking about the variant acute promyelocytic leukemia, you will find out that they lie in the monocytic area. And now you will have to differentiate between the acute promyelocytic leukemia and the monoblastic leukemia. You have to revise this by heart if you are going to use the flow cytometry in diagnosis. Regarding lymphoblasts, they also match many differences on your graph of flow cytometry. Sometimes the acute lymphoblastic leukemia have a bimodal expression of CD45. As you can see in the first graph, some are lying in the CD45 negative area, while others lie in the DEM45. So they are extending from the negative till the DEM expression of the CD45. This is what we call bimodal 45. Sometimes some of the B acute lymphoblastic leukemia lie in the negative CD45 only. And this is very important. Every population lies inside your graph if you are going to diagnose leukemia is actually under the question whether it is normal or abnormal. So you will have to examine all the population in your graph if you are going to use flow cytometry for diagnosis. Then, lastly, there is the T acute lymphoblastic leukemia, which has a lower side scatter than the monoblast and a moderate expression of CD45, even more expression of 45 than the subtype. The second question that you will have to answer, how to identify the blast? If I find any kind of abnormal population, how I can get sure that this population is actually mature? How can I get sure of this? One of the reasons you can get, one of the explanations you will have to give to the people you are going to train, that they will have to know the normal by heart so that they can identify the abnormal. Let's first distinguish what are the markers of immaturity. And the markers of immaturity as CD34, CD38 TDT, and CD117. So you have to know also what are the maturity markers that your population must not express, like CD11B, CD15, CD16, and CD65. So now you have a population with immaturity markers while it lacks the maturity markers. This is very important if you are going to see graphs of flow cytometry and you are going to reach the diagnosis, that you will have to know those markers by heart. CD34 cut off from only 10%, CD117, and you will find what is the importance of this marker, while CD34 is negative. CD38, which is expressed on normal stem cell as a sign of immaturity, and the TDT, which is an intranuclear antigen, which is positive mainly in acute leukemia, some of the subtypes of the acute leukemia. So those four, please revise by heart, as you are going to use very much in the coming journey in diagnosis of acute leukemia. We have a lot about CD34, and we have said that it is very important for the diagnosis of leukemia. Still, you remember that some of the blasts you are going to examine by nature, they do not express CD34. Like pre-ALL blasts, those are going to reach the maturity, and they are to be naive B cells. While this level of maturation, they can lose CD4 and gain CD20. The acute lymphoblastic leukemia usually do not express CD34. Pure erythroid blast, the monoblast, megakaryoblast, and acute myeloid leukemia blast with nucleophusmine mutation, usually they do not express either 34 or HLA-DR. So if I have a population which is negative to CD34, how can I know for sure that it is immature? If you want to answer this question, you will have to know the normal maturation series and the importance of some of the antigenic structures like CD117, as it may accompany you as a wonderful friend in so many cases when CD34 is negative. I have given you here some of the clues. Those are used in the WHO to assign the lineage of your population, as according to the revised WHO of 2022. Now you have to assign the lineages to either myeloid or T lineage or B lineage according to specific characteristics. In case of the myeloid lineage, the myeloperoxidase lies in the very most important. Usually you find it cytoplasmic, and maybe in some other occasion when we have more time to see, to separate the antigenic structures between the surface cytoplasmic and the internuclear. But now you will just have to remember that actually myeloperoxidase is actually one of the most important markers if you are going to assign myeloid differentiation. While the monos differentiation, you have to be sure that you assign the monocytic lineage when you have two antigens. Please, you have two antigens for monocytic differentiation. And remember this by heart. Do not settle for one. You have two of the coming CD11C, CD14, CD64, and the lysosomes. In order to assign for the T lymphoblastic lineage, please remember cytoplasmic CD3 and the surface CD3 is very important. Cytoplasmic is even more important, but you have to put in consideration that your monoclone has to have an epsilon chain antibody. This is very important, and some of the zeta genes are actually assigned to another lineages. While the B lineage, you cannot have a specific marker assigned to the B cell, and this may seem strange for some of you, as we do. CD19 is very important B cell identification. Yes, I would agree with you. CD19 is very important, but please remember that according to the WHO, you have to assign another antigenic structure to diagnose B cell leukemia due to increased expression of CD19 in many, many types of appearances, as we are going to see today. You will see here that CD19, if it's going to be strongly expressed, how do you know if it is strong or weakly expressed? Due to the intensity of the antigen structure on the blast population in relation to residual lymphocyte. It has to be exceeding 50% if you are going to say it's strong, and less than 50% if you are going to assign it as weak. If it is strong, you can assign it to the B lineage if it is accompanied with either one of CD10, CD22, or CD79 alpha. If it is weak, please assign both of the listed markers, CD10, CD22, or CD79 alpha. Please remember that if you are going to be I don't know how to say it, if you are going to assign to the T cell lineage and you are not so sure if the T cells is one of the populations you are going to find in your acute leukemia, please exclude CD79 alpha from the assignment to the B lineage. Usually the T and the myeloid can be accompanied. The B and the myeloid can be accompanied. Very, very, very rare to see the B and the T. But if you are not sure and you want to assign the T lineage to the cells you are going to examine, please exclude CD79 alpha from your panel. So once again, for the MPO for the myeloid, the monocytic 2 of the coming CD11C, CD14, CD64, or the lysosomes. Using the cytochemistry, you can use the non-specific estrays. If you are going to assign to the T lineage, please remember cytoplasmic CD3, and please remember that the antibody you are going to use is using an epsilon chain. If the B lineage, yes, you can depend on the CD19 according to its strong or weak. If it is strong, use one of the coming CD10, CD22, CD79, A accompanying it. If it is weak, please use two of them. If you are not sure that you are going to assign the T cell lineage, please exclude CD79A. Usually, most of the highly specific flow cytometry labs now are using the Euroflow antibody panels, and I have given you here one of the sites which you can enter and you can download all of the Euroflow panels. Those are used in all the developed countries. But according to our financial problems and some of the problems we are going to face in Africa, sometimes, yes, we do not actually follow these rules, but you should aim for it. You should aim for it for standardization of your panel and standardization of your experiment. This was the most primitive panel we were using before, the Euroflow panels, to assign for the acute myeloid leukemia and acute lymphoblastic leukemia. We were using tubes first. We were using first-line tubes to assign the lineage. And usually those tubes contained the CD19, 22, CD79, and the T cell lineage, cytoplasmic CD3, and acute myeloid leukemia markers of the NBO 13, 33, and 170. Some of the non-specific markers have to be included in your panels, like the TDT, HLA, DR, CD34, and CD38. Then the second line of the tubes to demarcate the maturation of the population you are dealing with, like the cytoplasmic mu and the surface immunoglobulin in case of the B cell, CD1A in the T cells, and CD4, CD8, and anti-TCR, which is now a very popular and a very famous antibody used in all the flow cytometry labs. Then the second line in acute myeloid leukemia contained the erythroid markers and the megakaryocytic markers. Anti-glycophorin A is actually CD235A marker. In order to diagnose acute myeloid leukemia, please remember those coming points. If you want to see to set the revision between the key changes of the WHO 5th edition and the 4th edition. In the 5th edition, they have eliminated the previous term of acute myeloid leukemia not as a wide specified. Now they are listing it into acute leukemia based on differentiation. Also, they have eliminated the condition of presence of 20% of blast for requirement of acute myeloid leukemia in case you are going to diagnose acute myeloid leukemia with defining genetic abnormalities. The increased importance of the genetic and the molecular studies. And I'm sorry to say that actually, according to the fifth WHO edition, the importance of the molecular studies has even exceeded the flow cytometry examination. And you will see by your own eyes why. They have kept only the 20% of blast as option to diagnose acute myeloid leukemia in two categories. Then they have removed the blast cut-off required in only correlation. The immunophenotyping and the morphology are so much considered when you are going to depend on them if there are no molecular and genetic studies are positive. Still, if there are positive, the final word. You can see in here as the actually move the differences between the WHO fifth edition and the fourth edition. And let me tell you that according to the fifth edition, we have two big categories of acute myeloid. This is the part in which you can see that they have actually removed condition of presence of 20% blast if you are going to diagnose, unless the two categories that we have mentioned, those are the BCR, ABL, and the CPEP. They have eliminated the part of acute myeloid leukemia, not as it was specified, which was found in the fourth edition, and now they are actually replacing it with acute myeloid leukemia with defined by differentiation. So they are defined by differentiation. They have removed the acute promyelocytic leukemia from this category, totally depending on the PML RARA fusion gene, which is a demarcation for the acute promyelocytic leukemia, whether it was hypergranular, or basophilic. There is a new term now which is found. This is called acute myeloid leukemia with other defined genetic alterations. And you can find the RUNX, which is eliminated from the RUNX mutation, which is eliminated from the fourth edition. As we have came to agreement that in order to diagnose the abnormal, you have to know by heart the normal. And this is the part we have saved from the last lecture I have met with you to demarcate the normal markers during the maturation so that you can see the maturation arrest has stopped in where. So let's understand what is the normal maturation of the myeloid cells and the development markers as long as they are going to mature. You can see in here the CD34 appears from the very first beginning within the blast. And you can see that I am going to move the arrow while the antigen is going to be created and when it's going to be declined. So you can see CD34 is found during the blast, and you can see the differentiation and the maturation level in the uppermost part of the graph, which actually which correlates to the part we are going to talk to the antigenic structure we are going to talk to. CD34, which is the right, the red curve, appears from the very first start of the blast series and then continues to the early part of the promyelocytic maturation and declines by the end of the promyelocytic maturation. It's totally different when it comes to the myelocyte, and now you can understand why we do consider the myelocyte as some of the maturation part of the myeloid series. You can see, once again, CD34 here begins from the start of the blast and declines as the promyelocyte is going to start. While CD117, which is the red, the deeper red color, starts from the very first beginning of the blast and declines by the end of the promyelocyte. So it demarcates wonderfully the immature compartment and the mature compartment of the myeloid series. You can see some of the maturity markers like the CD45 and CD65, CD15, and CD16. They start by the start of the myelocytic lineage and they continue to appear till the end stage of maturation and the appearance of the neutrophils. You can see here that the CD45 in the baby blue starts from the very first beginning when the blast appears, and it starts to continue till reaching the neutrophil, taking a higher intensity. This may explain to you why the monoblasts have a dim expression of CD45 while a higher expression while it is on the end stage maturation and the formation of the neutrophil. Some of the important markers I would like to demarcate is the CD33, which starts from the very first beginning in the green color and goes with the maturation till reaching the metamyelocyte stage, and then it starts to decline. You can see that the maturation marker CD11B starts from the beginning of the myelocyte and then continue till the end of maturation. CD10, on the other hand, is one of the very handy and the very famous markers which demarcate the neutrophilic maturation. As you can see, that they only start to appear by the end of the metamyelocyte and the band development and the start of development of the neutrophil. So these curves, as they may look kind of actually sophisticated, but they are summarizing the whole story. And you will understand as we will pass through the flow cytometry diagnosis of acute leukemia, why it was important to say this diagram. Please remember the CD34 declines after the blast series ends and then starts to disappear by the level of the promyelocyte appearance, while CD117 starts from the very first beginning of the blast development and declines only after the promyelocyte series, while it is totally disappearing on the myelocyte. Remember those two markers as we are going to use them a lot. If we are going to talk about the importance of the antigenic structure for the assignment of the lineages, please remember that MVO takes the uppermost importance, while it comes below the CD117 and some of the people on the chat are saying that they do not see the demarcations. I don't know, does it appear for you now, or you still don't see it?
Yes, Prof, there is there is one statement called please move the window away from the sharing application. I don't know. It's hiding some statement in the screen. It appear and disappear sometimes. I'm not sure where, but we try.
Yeah, but I have no control in it actually. This is not from my side.
Yeah, that's why I don't know. Okay, just
Yeah,
carry on.
this is the thing they were talking about on the chat. If that is, I'm sorry, I have no control
Blue
in it.
box, yeah, look, blue box. I'm not sure you're able to see it or not, because everyone see that blue box disappear and appear every time.
Not from my side, I'm sorry.
Okay, now, okay, okay, carry on, Prof. Don't worry, just.
Okay.
Okay.
Then comes the monocytic differentiation, and as we have said that according to WHO, we have to find two antigenic structures to assign the monocytic lineage. Please remember some of the antigenic structures that you have seen within the myeloid are going to be seen strongly with the monoblastic. Talking about CD34 appearing in the monoblast and then declines before the pro-monocytic lineage development. And CD117 once again appears on the monoblast, but in here it declines before the pro-monocytic lineage develops. Some of the maturation markers that you have seen in the myeloid still present in here, like CD11B, CD15, and CD11C. You can understand why, for the assignment of the monocytic lineage, the WHO have put the condition of two antigenic structures. One of the most famous antigenic structures to define monocytes are the CD14. Can anyone see when does the CD14 start to appear on the monocytic lineage? Here is CD14 actually. Does anyone here see when it appears? Can you write in the chat, where do you see it? Is it found on the blast? Is it found on the blast area? Yeah, right, Reham, right. No, it's not found on the blast area. And this is why you can see why it is important not to depend on CD14 to assign to the monoblast. Once again, what about CD4? It only appears by the end of the monoblastic development. What about CD64? Only in the middle of the monoblastic development. So now you can understand why the WHO has put this condition when you were talking about the monoblast. So presence of two of those lineages, and sometimes depending on the non-specific strains using the cytochemistry, is important to assign the monocytic lineage. So you can see that, yes, those graphs looks like they are complicated, but actually they are setting the whole story for you and they are saying everything for you. Now let's start with acute myeloid leukemia defined by differentiation. And why did I start by the acute myeloid leukemia, which is defined by differentiation, not those with the recurrent genetic abnormalities or the defining genetic abnormalities? Why did I do this? Because actually in the other set, the molecular takes the upper hand. While in the acute myeloid leukemia defined by differentiation, you can depend on the flow cytometry in relation to the morphological characteristics that you are going to see, as most of the recurrent genetic abnormalities are usually negative. Some of the shared diagnostic criteria that there is more than 20% loss have to be assigned so that you can diagnose type of leukemia. Criteria for acute myeloid leukemia with defined genetic abnormalities are not met. This is very important. If there is any of the defined genetic alterations, it is going to be assigned to the this specific alteration subtype, not to the to this category. The criteria of the mixed phenotype acute myeloid leukemia, acute leukemia has not to be met. Not fulfilling the diagnostic criteria for myeloid neoplasm post cytotoxic therapy. There has to be no therapy of cytotoxic drug, and there has to be no history of myeloproliferative neoplasm. So those criteria have to be met strictly before you diagnose your leukemia using the flow cytometry. Let's start with number one, which is acute myeloid leukemia with minimal differentiation. And as we have said, that now you will have to combine both the morphological diagnosis and also the flow cytometry diagnosis. Remember that some specific criteria have to be defined to define the minimal differentiation subtype, which is the negativity of the MBO. And usually you assign the positivity when it is more than 3%. So A negative MBO by immunohistochemistry and flow cytometry is a must if you are going to diagnose acute myeloid leukemia with minimal differentiation. As you can see here in the first plot, in which we have used CD45 against side scatter, there is the area of blast. Can anyone tell me, does it lie in the dim CD45 or negative CD45, or does it lie in the positive moderate expression CD45? Can anyone tell me those types of blast lie in what area according to the CD45 expression? This you can call what? Negative 45, dim 45, moderate or high expressing CD45. Which type is that one? Come on, guys, you can write in the chat. It takes a second, please. Anyone? Okay, this is in the negative CD45 area. So you can see some of the blast. Actually, it is negative. It is negative, guys. It's near the zero in here. So yes, not all of the blast lie in the blast or the window area we have talked about. This is a CD45 negative blast as a kind of example that we are taking here. Now you can see that it is positive for CD34, and it is positive for two of association markers of the so you can see CD117 and you can see CD33 in the below, while CD13 is negative. HLA-DR is expressed. So here, to define acute myeloid leukemia with minimal differentiation, you must have a negative MBO. You must have two of the association of myeloid markers because you will have to depend on them due to the negativity of the MBO. Then comes acute myeloid leukemia without maturation. And here you will find a positive MBO. Now you can see that the blast, which is the blue population, lies in the dim to moderate 45 area of expression. You must have more than 90% blast of the non-erythroid lineage. And 10 of less than 10% of the bone marrow manifest maturation. The maturation could be the presence of promyelocyte, myelocyte, neutrophils, metamyelocyte, not just neutrophils. The MBO, which is expressed, is usually accompanied with one of the myeloid-associated markers. So the MBO is positive with CD13, CD117, or CD33. Usually one of them is assigned with the MBO. You can see here from the morphology that more than 90% of the bone marrow is formed of blasts. And you can see in the lower figure that the MBO is positive by cytochemistry. Now, by flow cytometry, here is the blue population, which is the blast area. Here comes, it is 34 positive, 117 positive, HLA-DR is positive, 33 is positive, and sometimes 64 is expressed on those blasts. Then comes acute myeloid leukemia with maturation, and you can see that more than 20% of the bone marrow is formed of blasts, and there is a maturation series representing promyelocyte, neutrophils, and the band cells. And they are representing more than 10% of the bone marrow. The monocytes have to be less than 20%, and I will tell you why. But here, once again, you can see that in the window area lies the blast area, and this is our population of interest. You can see the CD117 is positive, CD34 is partially positive, partially negative. 11B in the lower graph is partially positive, partially negative. CD11B is a marker of what? Does anyone remember? CD11B is a marker of what? Do you remember the maturation markers that we have talked about? CD11b, CD15, CD65. This is a marker of maturation that you will find it in asynchrony to the blast presentation, and you will find it very commonly in acute myeloid leukemia with maturation. As we said, one of the associated markers of the myeloid, lineages can be found like CD33 in this part and CD13 in this part. Please, you can see in the first graph, I want to demarcate for you that the neutrophils are present. You can compare between this photo and the previous photo, because in the previous photos, when we were talking about the minimal differentiation and the minimal differentiation, you can find that there is actually no neutrophils in here. And when you were talking about acute myeloid leukemia without maturation, you can find no neutrophils in here. While now we are going to the subclassification of acute myeloid leukemia with maturation, now you can see that the site of the neutrophils is very apparent in your graph. So once again, I remind you, all people who are actually using the flow cytometric or the diagnostic myeloid leukemia or acute leukemia in general, please remember to examine all the population in your graph. Please remember what is the normal so that you can diagnose the abnormal. Then comes acute myelomonocytic leukemia. And here you are dealing with two types of blasts. Why are you going to deal with two types of blasts in here? Because actually you have two types of blasts. One of the criteria of definition by the WHO, that both neutrophils and their bursa have to contribute to more than 20% of the bone marrow. And the monocytes and precursors to contribute another 20% of the bone marrow. So actually you have two types of blasts. One of them is MPO positive, this is the myeloblast, while the other is MPO negative, it is the monoblast. So here you can find, even without me telling you anything, that you can find signs of maturation due to the presence of neutrophil area. You will find two blasts, and one of them is positive for CD34, that is usually the myeloid blast, while the other blast in the blue color is negative for the CD34, and this is one of the common characteristics of the monoblast, as they are not usually expressing CD34. CD117 can be present on the myeloblast while negative on the monoblast. CD11C, which is a maturation marker, is present on both series. Same goes with CD14, is only present on the monocytic lineage. And you can see that it is totally negative on the myelocytic blast that is in the green color. Regarding CD64 and CD33, you will find 64 is more expressed on the monoblast in the blue population and less expressed in the myeloblast in the green population. So you can see from what I'm talking about that in the myelomonocytic leukemia, you are actually talking about two separate blasts. One of them is even MBO positive, that is the myeloblast, and one of them is MBO negative, that is the monoblast. And each one of them is showing antigenic structure. So now you understand why knowing the normal maturation and knowing the normal antigenic expression on the series of cells that you are examining is so important in order to reach your diagnosis. Then comes the acute myeloid leukemia with monoblastic only differentiation. and there is no myeloid differentiation in this subtype. So all the blasts are monoblasts and all the blasts are MBO negative. They constitute more than 80% of the bone marrow. So more 80% of the bone marrow is actually consists of monoblasts. In acute monocytic leukemia, most of the monocytic cells are promonocytes or monocytes. One of the differentiation part between the monocytic part, if you're going to set the maturation arrest has stopped on the monoblastic level or reach it out to the monocyte level is CD117. CD117 is usually negative on the pro-monocytes, if you do remember. It is represented in this graph. So you can see it is all negative in this graph, and the population is CD117 negative. Some of the acute monoblastic leukemia express CD56. This is a very common occurrence in this subtype. CD33, CD64, and CD14 is expressed. But due to the immaturity of the monoblast, you have to remember the CD14 can be negative on some of the population of the monoblast, and this is why you can see the CD14 extends its expression from the negative part to the positive part. This is what we are calling the smearing of CD14, as its expression is actually starting from the negative part. Some of the population is totally negative for the CD14, while other parts is going to gain CD14 as they are going to develop to more mature forms. This is once again to remember the smeary look of the CD14 expression when you are talking about the monoblastic differentiation. You can see that it extends from the negative to the positive. While actually, if you are going to deal with mature monocyte, you will see that CD14 does not have a negative compartment, and the monocyte expresses CD14 with high intensity. Same goes with CD11B, which is a marker of maturation. The acute erythroid leukemia, one condition has to be present is the presence of 30% pro-erythroblasts. Now, your population here of interest is the blue population. You can find it is CD34 negative, and this is one of the populations that we have talked about. Those do not express CD34. CD117 can be expressed. Most characteristically is CD71, which is the transferrin receptor, and the glycoprotein A, that is CD235. You have to know that the erythroblast can be sometimes tricky due to each maturation stage, because what is most common erythroblast that it is CD5 negative. A erythroblast can express CD4 if they are very primitive, very pure, as start to lose CD40 and to gain CD36 as they move toward maturity. So actually, what is more common and what is famous that the erythroblast is usually negative for 40, but you have to remember that some of the cases you will find that CD45 is expressed on the erythroblast if it is very primitive and very immature. The megakaryoblast differentiation of acute myeloid leukemia is the very most easiest to actually to diagnose, because it has very characteristically positive CD41 and CD61. Regarding CD45 expression, usually megakaryoblast are negative for CD45, but some of the cases they are positive for CD45. Remember that some of the megakaryoblast do not express CD34, but this case is expressing CD34. So you can find, yes, there is a common, but you can see the least common in so many cases. CD117 is usually negative, and HLA-DR is usually negative. They do not express CD2. CD33 can be expressed as CD64, but the most characteristic of them all is one which is co-expressed with CD34, in this case, CD1, which is co-expressed with 34. Please remember that some of the cases are positive for 45, while the most is actually negative for 45. One of the criteria which has to be present to reach the diagnosis of megakaryocytic acute leukemia is the presence of 20% blast, of which more than 50% are of the megakaryocytic lineage. This is very important. The blast, then comes the basophilic leukemia. Here, there is a specific characteristic, which is the metachromasia with the toluidine blue staining. As you can see, blasts are negative for the cytochemistry examination of the MBO and the sodium black 3 and non-specific strains. There is no expression of CD117. Blast can express some of the myeloid-associated markers like CD13 and CD133. That is the 13 and 13 and 33, while CD123 is expressed and CD203, unlike the normal basophils. Unlike the normal basophils, they express the HLA-DR. So the most important characteristic finding is the toluidine blue staining that gives a metachromasia while you are actually examining this type of blasts. Now comes the next category, which is acute myeloid leukemia with defining genetic abnormalities. And now you can see why did I get it in the second category, not the first category, as say that the molecular is going to take the hand, and you are going actually to reach diagnosis only by the molecular studies. The second category, which is the acute myeloid leukemia with defining genetic abnormality, now you will have to depend on the presence of the genetic abnormality and the molecular studies. Still, the flow cytometry can help the associating presentation while you are diagnosing it. You will see this by heart when in the coming slides. But let me remind you, the fifth edition of the WHO, the diagnosis criteria are unchanged in some of the categories, like the acute pro-myelocytic leukemia, acute myeloid leukemia with RANOX and RANOX T1 fusion gene, acute myeloid leukemia with core binding factor beta fusion gene, acute myeloid leukemia with DECNAB 214, and the MRT F fusion gene. The categories are still the same. You will have to have at least 20% of blasts to diagnose two categories, that is BCR ABL fusion gene and the CPEPA mutation. There are newly recognized rearrangements. Those are the KMT2A and the MECOM rearrangement and the NOP98 rearrangement. You can see that the KMT2A rearrangement has replaced what was known in the acute myeloid leukemia of the fourth edition, like the acute myeloid leukemia with translocation 911. We have two categories. Those are the acute myeloid leukemia defined by mutations and this, remember that we have in this and the BCR ABL, there has to be more than 20% loss in order to reach the diagnosis. So actually, if you are going to match the flow cytometry to those molecular studies, you can reach something. Actually, you can, but the dependence is in this category. You have to know by heart it is going to be for the molecular studies. Let's start with the acute promyelocytic leukemia with PML-RARA fusion gene and the presence of three subcategories: the hypergranular, and the hyperbasophilic. By flow cytometry, as we have said in the very first start, that the acute promyelocytes lie in the neutrophilic area. As they are showing more maturation and due to the presence of the granules, they are taking high side scatter. And so you will find the two population of interest lies in the neutrophilic area. They are negative for the CD34 and typically negative for the HLA-DR, while CD117 can be positive. CD13 is expressed and CD33 is expressed even higher than the neutrophils, the normal residual neutrophils, and CD64 is usually negative. The acute promyelocytic leukemia with the hypogranular differentiation, you will find that it lies in the monocytic area, so it has a lower side scatter. Please remember that, yes, you cannot reach the diagnosis without remarking the fusion gene PML-RARA. Here you can find the sum of the CD34 is the CD34 can be expressed on the promyelocyte. This is actually in the variant hypogranular type, not in the hypergranular type. CD117 can be positive. HLA-DR is typically negative. CD13, CD33 are expressed, and CD2, which is a T lymphocytic lineage marker, is usually expressed as apparency. Please remember that you have here to compare between the monoblast and the hypogranular acute promyelocytic leukemia. If you are going to use cytometry, definitely with the presence of PML-RARA, the situation is done. But if you did not reach the molecular studies and you want to get sure, please remember that HLA-DR is very powerfully expressed on the monocytic lineage, while you cannot find that in the myelocytic lineage. So HLA-DR is very handy, and it comes into your hands when you want to differentiate between between promyelocytic leukemia, that is HLA-DR negative, and the monoblastic, which is HLA-DR positive. CD117 can be negative on the monoblast, while it is very well defined in the acute promyelocytic leukemia. CD34 is usually negative on the monoblast. It is one of the blasts. Those are not expressing CD34, while you can see 34 is expressed in the hypogranular variant of the acute promyelocytic leukemia. There comes the acute myeloid leukemia with RUNX1 fusion gene. You will find that it has a specific, actually morphological characteristic due to the indentation happens by the Golgi apparatus. So you can find this indentation very well on the bone marrow smear. The our rods usually are present, and you can see that it moves toward representation of a mature myeloid differentiation. So the immunophenotyping of the acute myeloid leukemia was defined by mutation. Now you can assign the immunophenotyping of them, knowing the subtype, to the acute myeloid leukemia with the genetic abnormalities. Now you can see that if you have a RUNX1 and which is correlating usually with mature myeloid leukemia, you will find the myeloid lineage antigenic structures like CD13, CD33, CD117, MBO, CD15, and CD65 are usually present as maturation markers, but characteristically, CD11B is not defined. Acute myeloid leukemia with inverted 16. This is one of the most famous types due to presence of a fusion gene between co-binding factor beta and myosin heavy chain 11. It represents usually acute myelomonocytic leukemia. So by heart, you know now that you will find lost. One of them can be positive for 34, other is negative for 34, and you can find one is MPO positive and the other is MPO negative. Usually, it expresses CD2 as an apparent expression. Then comes acute myeloid leukemia with NUP 214. It is usually taking the shape of myelomonocytic differentiation. Usually, you will find that dysplasia is very common. So you will have to know what are the dysplastic characteristics. Sometimes you can find high granular neutrophils or hypergranular neutrophils, Shinya-Higashi abnormality. The generic myeloid immunophenotyping is usually going to be present. You will find CD13, CD33, CD100. CD123 is expressed, and you can find some of the maturation markers in CD65. Acute myeloid leukemia with the RBM15 fusion gene. Here you can find that the blast tends to take the megakaryocytic differentiation. You can see in the blood film smear that you can see micromegakaryocyte. Usually, and remark these words, the dysplasia is absent in the myeloid and the erythroid lesion. Please remember, as you will have to differentiate between it and the other subtype of leukemia associated with myelodysplasia, because the dysplasia in here is actually confined to the myeloid lineage. Sometimes you have to remember the antigenic structures on the megakaryocytic leukemia that we have talked about it later. And please remember that it is more specific to examine CD41 and CD61 in the cytoplasmic compartment than on the surface. Why is that? Because some of the megakaryocytes usually tend to express platelets as they are coming from shedding of the cytoplasm. And platelets actually express CD41 and 61. So sometimes when you are examining surface markers of 41 and 61, you get the positivity coming from the platelets sticking to the blast and not the megakaryoblast. So the more specific is to examine 41 and 61 cytoplasmic. Sometimes you can see some of the non-specific markers like CD34 and TDT. Remember that whenever you are going to mention dysplasia, even in the myeloid lineage, usually they are accompanied by CD7. There are three newly introduced categories in the acute myeloid leukemia. Those have a flow cytometric association. KMT2A, which represents the fourth edition WHO categorization of translocation 911, and the MECOM and NUP98. All of those rearrangements have to be, you have to be very careful while you are using conventional karyotyping, as usually they will appear cryptic. So please do not depend on conventional karyotyping. Acute myeloid leukemia with KMT2A, without any saying, you are going to know it is usually related to the differentiation in the common sense of the population, while actually in the normal scientific form, it is not related to any morphologic or any immunophenotypic clue. While we were in the fourth edition, we were assigning the KMT to a rearrangement to the monocytic differentiation mostly blindly. Now, as we are toward the fifth edition, we can find that taking many morphologies, sometimes even not related to the monocytic differentiation, but still they can express the monocytic antigenic structure. Some of them are expressing CD56 and CD7. Usually there is difference between the adults when they are expressing this type of rearrangement and the children. When you are talking about the adult, they can take the monoblastic differentiation. The morphology can be assigned to the monoblastic differentiation. While in the childhood, they can take the megakaryoblastic differentiation. And this is why you can see that I have demarcated by red that there is no strong, neither morphologic or immunophenotypic clue. You can only reach these subtypes of rearrangement and assigning them if only you are going to do the molecular studies. Please remember, do not depend on the conventional karyotype. This type you will find this is a case of an adult patient. You will find that he is negative for the MPO, negative for CD19, and negative for CD79A, while he is positive for CD123 and CD117, positive for CD64, and apparently expressing CD7. So once again, remember that KMT2A rearrangement, I don't have a specific clue. It is going to be different according to the age of your patient, whether it is adult or children. And in children, usually it takes the megakaryoblast appearance. Then comes acute myeloid leukemia with the MECOM rearrangement. You will find severely dysplastic neutrophils, some in the peripheral blood. Sometimes they do not retain the blast in the peripheral blood, and they are retained inside the bone marrow. The red cell dysplasia is minimal, while the platelets can show giant and hypogranular platelets. No specific flow markers, but usually CD7 is present. Acute myeloid leukemia, 98. Please, once again, remember, do not examine it with central karyotyping. Acute leukemia defined by mutations. We have two categories in here: acute myeloid leukemia with CBEPA mutation. This is due to biallelic single mutation. It's only characteristic if it is located in the BZ region gene, but usually going to depend on biallelic mutation. It has a favorable prognosis to diagnose dysplasia, and please remember that whenever you are going to say this comment, you are going to say is acute myeloid leukemia with mean mutation. The diagnosis in here is irrespective of the blast count, unlike the CBEPA mutation. As you remember, two cases we have said that going to take 20% blast for diagnosis of acute leukemia. It is going to be the CBEPA mutation, the BCR-ABL, but the nuclein mutation, once you find 1%, irrespective of the blast count, usually the bone marrow is hypercellular, and it takes the morphology and phenotype of the myeloma. Acute myeloid with BCR-ABL fusion gene, this was a prospective subtype addition WHO. Now it is assigned to a specific acute myeloid leukemia subtype. It has a broad spectrum. Please remember that you can find CD19 as a parency and CD7. CDT is common in this subtype. Usually it expresses the myeloid expression antigenic structures like 34 and HLA-AD and 13 and 33 HLA-ADR can be positive also. Usually the morphology tends to be toward the minimal differentiation or the monocytic differentiation. Remember that you need to assign to this part only if you find more than 20% blasts. There comes the acute myeloid leukemia, myelodysplasia related, and now they have to be more than 20% blast to assign for this subtype of acute myeloid leukemia. The key changes which happen from the fourth edition, that removal of the morphology alone for the diagnostic, we don't know the morphology. The cytogenetic criteria are actually renewed. The introduction of mutation-based definition on the set of 8 genes, the presence or one or more of the cytogenetic or the molecular abnormalities listed on the table, or history of myelodysplasia or myelodysplasia, myeloproliferative neoplasms are required for diagnosis of acute myeloid leukemia. Acute myeloid leukemia transformation of new is in the myeloproliferative, while acute myeloid leukemia transformation of MDS and MDS myeloproliferative neoplasm is kept under the acute myeloid leukemia with myelodysplasia relation. As there is so much relation to the flow cytometry to these categories, I will just pass by them so that we can reach the acute blastic leukemia. For reaching this category, I really need you to remember what we have said when we said that there sometimes a parency of the blast, and to differentiate the parency with the presence of acute myeloid leukemia with mixed, because when there is parency, you can see that there is one genetic structure that is assigned to lineage that you have definitely demarcated, like when you are seeing CD19 on an MBO positive lineage. So only CD19, there is no CD79A, so this is actually a parency. You have to remember this. Sometimes the apparent antigenic expression, sometimes there is synchrony in the expression of antigenic, some of the blast expressing immature markers with the mature markers. So you can see a cell with CD34 positive and CD65. 34 is an immaturity marker, while CD65 is antigen express the mature markers. So defining the apparency is very important if you are going to assign your the apparency can be your clue for the minimal residual disease modality. Unfortunately, I have to speak representation of sensitivity between flow cytometry and the molecular. Definitely, the flow cytometry is going to be less sensitive, but you are on the presence of apparency in your diagnosed population in order to find out the minimal residual disease if there is recurrence. But of course, this is not to be our scope in this in this lecture. Then we are going to acute leukemia, subcategorized into the T cell and the B cell. Let's remember first that the T cell has a specific maturation characteristic, because once it's in the bone marrow and find it is going to express CD7, while surface CD3 is not even appearing, or is not appearing. Reaching the thymus, you can see that there is going to be accompanied by cytoplasmic CD3. You can see in here that the cytoplasmic CD3 is going to actually start appearing in the cytoplasm. As we develop the mechanism, the cytoplasmic CD3 is going to reaching the cortex, the thymus, it will be at negative with no before it's going to be double positive. So it's going to express CD4 and CD8. As it reaches the medulla, they're going to express CD4 or CD8, being a T helper or T cell. I want to get to knowing that reach times it has CD50, and that is going to be natural T. Please remember that the T cell either alpha beta or gamma delta. The gamma delta is going to be extruded to the periphery after the according to the WHO classification of the fifth revision, they have identified 5 immunophenotypic categorization. The pro-TLL that is defined by the presence of CD7 and cytoplasmic CD3. The pre-TLL it's either double negative or double positive. And one of the important demarcations is the appearance of CD2 and CD in relation to the pro-T. The pre-T is actually expressed and CD5. Please remember that usually LDR is not expressed at the CD64. Cortical T now CD3 plus with CD1A. This is why they are the thymocyte marker. It is the CD. The mature T is either expressed CD4 or CD, while the HP is actually represented by CD13, 33, CD11B, and CD65. Please remember 30 very much expressed CD117. This is characteristic for E. For the B cell maturation and acute myeloid leukemia, characteristic presentation of the maturation series of the B ALL, as you can see that in the very beginning, broadly represents only CD19 with negative CD20 in association with the TDT and the CD4. As it's going to mature more and more, it is going to exceed, and now it's going to the common. And why it is important, because it has closes this antigen. Then, as it matures more, it's going to cytoplasmic mu, now called 3D, and this is the development part. CDT can be expressed with the loss. This is why we have said that the subtypes of the B acute lymphoblastic leukemia marked the 3DLL can be CD30 negative, while they are expressing the maturation marker of CD20. Then the surface IgM is going to be formed by the assembly of the heavy chain and the light chain, and then it is going to be followed by the IgD before the mature B cell is going to enter the peripheral blood and then enter the secondary lymphoid organ to complete its maturation to reaching the plasma cell. Being characteristically positive for this plasma cell is that it is CD138 and CD38 positive, while CD45 is usually negative in the plasma cells. You will find some of the papers are saying that the plasma cells are usually, if normal, they are CD45 positive, while if they are a compartment of a multiple myeloma pathology, they are going to be CD45. But what we have seen actually that the plasma cells is lying in the CD45 negative compartment. Some of the papers were talking about the association of some of the morphologic appearances of the B acute lymphoblastic leukemia with some of the rearrangements. Some are saying that some of the rearrangements like A is usually associated with ruby stuff. This is something to depend on. It is only association and correlation related populations, but I have mentioned the population because actually they are increasing the but usually depending on the flow to assign maturation of the BALL, you will have to remember that actually you have to include all the panel of the rearrangement before reaching a diagnosis only with the flow stoichiometry and the morphology. One of the challenges that you are going to meet in the
Hi, Prof. Can you hear us?
Yes, is everything okay? Did I have connection?
Yeah, because your sound is broken and you lost connection.
So do you just
Okay. Yeah, we can see your slide now.
okay. So I was talking about the hematogones and the challenge that they were representing when diagnosis be acute, as some of the bone marrow while even before chemotherapy can express hematogones, and you will have to differentiate between them and the norm and the B acute lymphoblastic leukemia dose. You will have to see that actually, if they are going to be present, they have a very low side scattering, even lower than the mark. Always BALM, while a subset of cases negative for CD20. The acute leukemia is positive CD20. Said that we have the type and the common subtype, and usually they are not expressing CD20. CD20 is the BLM. CD38 is expression on the malignant cells. CD58 the BA acute lymphoblastic leukemia may display apparent expression of the of CD33 while on the heme node. That usually they show when you get as they have different type of operation find in C10 negative, while they are moderate 10, 20, while stage 3 lose D10 and or even showing them CD20 to you can see this graph, it's 3 stages, where stage 1 is and the mature beasts represent stage 3, the very bright expression of
Bro,
CD.
sorry, bro. Your sound is broken a lot. I'm not sure your connection is good or not.
Do you see this one?
Your sound is broken. We couldn't hear
My
you.
sound is broken? So,
Yeah,
so
we can see the slide, but the sound is broken.
now you can hear me?
Yes, now it's okay.
Okay, okay. So I was saturation of hormone when you examine 20, you find out 3 stages and 3 regenerating bone marrow are negative for CD20, while showing them CD20 and CGC, which is the mature something for CD20. Which is either 90% positive here as they are representing regenerating. You can find different stages of maturation as you examine CD20.
Sorry, Prof. Still the sound is interrupted. I'm not sure if you can connect another connection. I'm not sure.
I have only 2 slides and I
Okay, good. Yes, Prof, you back? Hi, Prof, you back?
yeah, I'm back. Alhamdulillah. We are
Alhamdulillah.
going
Yeah.
to wrap up because I know that with you. I
Yeah.
was the type of acute leukemia, which is the mixed ambiguous leukemia. Yeah, which actually include 2 subtypes now. The differentiated leukemia, which is only one of the associated markers. Total of signing markers that we have talked about, whether the MBO, the cytoplasmic CD with epsilon chain, or the or the B cell CD19 is strong with 2 associated with 1 associated marker B cell, CD19, and 2 associated markers of the beast. The mixed phenotype again, when 2 lineages are the same leukemia. Well, actually, by this, I wrap up this this presentation, which I was honored to be with you. But still, I want you to remember that cytometry in the diagnosis of leukemia has its own limitations. Remember that now, as we are moving towards our studies, there are so more into this diagnosis only with flow cytometry or morphology. Also, cytometry is usually the number of blasts that you are going to examine is not sometimes so accurate as it is in bone marrow to the presence of dilution of the the take-home message that I want you leukemia is rearranged into two into the new subclassification of the WHO. The references that we have used in this lecture is actually going to be seen in here. Please remember to revise those 3 books. They are wonderful in relation to the diagnosis of leukemia. It was a challenge. Hope I managed to give it on. I hope we have more to talk in specific, but for now, have for you, and I'm open if you do have.
Thank you so much, Prof. It was a great and extensive lecture, informative and scientific. We run out of time, but I have 2 questions from my side. As far as you know, there is limitation of flow cytometry in many of countries in Africa, and use it to diagnose acute leukemia and differentiate it between type of leukemia based on morphological and cytology, sorry. And what my question, how many markers can you use it typically to standardize it or standard for diagnosis pediatric with acute leukemia based on immune stain, not based on immune phenotype?
Well, thank you so much for this wonderful question. Actually, it is representing actually one of the dilemma we are dealing with in the developing countries. But unfortunately, we have to move in a standardized way as we are using the same protocols of treatment they are using in the developed country. Reaching the diagnosis, now we have to use the Euroflow panels that I have given you the sites for it in order to standardize the diagnosis. Still, I am very aware that most of us are facing many of the financial in our countries, and we have to start from a very first beginning, even not below the 0, but we are starting. So I would recommend to use the primitive panel that I have shown you in the 15th slide. This one is showing is assigning first lineage of diagnosis, and then the immaturity non-specific, and then the second line for the maturation development. By this cytometry, you read this, but please remember that we are not going to diagnose acute myeloid leukemia on flow cytometry. We are not studies into our background. And seeing in the list of what I is rearrangements and translocations. You can read without those actually. So unfortunately, yes, flow cytometry is important, but now there is the extensive studies by which only you can reach the diagnosis of the rearrangement assigned leukemias in pediatrics.
Okay. And second, my question is a clinical practice question regarding what's the role of immunophenotype to distinguish between relapsed leukemia and the second evolution leukemia. It's easy, or you depended on cytogenetic for that time?
I would, as we have said, the slide that I have shown, the sensitivity of the flow cytometry and the cytogenetics. Yes, the flow cytometry lies below the cytogenetics if you are going to depend on the sensitivity. But still, with the presence of apparency, you can identify the minimum residual disease if you do have an apparency or leukemia-associated phenotype. Without this apparency, you will have to depend on the molecular studies and only the molecular studies. So this is to be very much clear about it. If you don't have a leukemia-associated phenotype to assign you MRD to, you can reach nothing to the MRD. Because without this apparent expression, how can you know the old from the new?
Thank you so much, Prof, for your time today and for informative and scientific lecture. I'm sure we will call you again for other lectures. Thank you so much for that.
Thank you so much,
Bye.
and thank you for having me today. Thank you so much.
Bye. Thank you so
Bye.
much.